Hello, I'm Erica Traxel. I have the joy of being the Urology Residency Program Director at Washington University in St. Louis. This video is intended to offer those who will be interviewing with us for a residency position an opportunity in advance of the interview to get familiar with our program. It's intended to give you an overview of our residency program, so hopefully you'll gather a lot of information in advance of your interview day. So welcome. We look forward to meeting you, albeit virtually, before too much longer. So I wanted to start off by introducing really those who are the heart and soul of our residency program. I wouldn't be here if we didn't have our residents. The purpose in showing these photos to you guys is so that you can recognize some of these familiar faces. When you are participating in the interview weekend with us, we will be having the Friday evening preceding our Saturday interview day. That Friday night, there will be a virtual happy hour when our residents will be tuning in, and they want to be a resource to you all. So no questions will be off limits, any questions that you have about our program. And I think that's really the best way for you to get a flavor for what the life of a resident at Washu in St. Louis is like. I also wanted to go through these slides just to show you the medical schools that all of our residents come from. As we go through here, you will appreciate how really we have residents who come to us from all over the country and even from all over the world. So currently our chief resident class is made up of 3 residents, but they are our last class of 3 residents per year. After them, we had made the conversion to add an extra resident to each year so that subsequent years all have 4 residents per year. So ultimately, come next year, we will have 20 residents total. We will be 20 residents strong. So Dr. Meng came to us from the University of Rochester, Dr. Parker from University of Oklahoma, and Dr. Ronstrom from the University of Minnesota. Dr. Agamawi also from the University of Minnesota, Dr. Argaday from University of Pittsburgh, Dr. Henning from University of Iowa, and then Dr. Lee from University of Washington. They make out our PGY4 class. Our PGY3s, this is our more, you could say, international class. Dr. Al-Kazmi did medical school at Duke University. Dr. Barashi, he did medical school down in South America in Colombia. Dr. McLaughlin, he came to us from Georgetown University, and Dr. Pickersgill was a WashU medical student. In our PGY2 class, Dr. Kim went to East Virginia Medical School, Dr. McCormick from the University of Washington, Dr. Ngo from also the University of Washington, and Dr. Wong from UT Southwestern. Our current interns, Dr. Campbell went to medical school at Vanderbilt. Dr. Gross was a WashU medical student, Dr. Jang from University of Nebraska, and Dr. Cooper Sirkul from UT Southwestern as well. We love working with all of them, and it's always a pleasure to me to witness everyone's growth over the course of their residency training. So what is it that our residents are doing over the course of 5 years that they are with us here? So this colorful schedule gives you an idea of what the rotations are that our residents are participating in over the course of 5 years. Our interns spend half of their year on the urology service at our main hospital, Barnes-Jewish Hospital. The other half of the year, they are on general surgery rotations as required by the ACGME. And those rotations also happen at Barnes-Jewish Hospital. And it's not consistently 6 months consecutively general surgery, 6 months consecutively of urology. Usually it's a little more mix and match within that year. But already within the intern year, we get our interns to the operating room as much as possible. Our consult resident grabs the interns and takes them along for bedside cystoscopy. So they're getting in the mix of it pretty early on in their training. Our PGY2 year, it is split up into 4 different 3-month rotations. You can see there's a lot of yellow on this grid, and our residents spend a lot of time at the John Cochrane VA Hospital. I think the VA system, there are so many of our veterans who have urologic concerns that this really makes for very rich educational opportunities for our urology residents. So in the PGY2 year, they spend 3 months at the VA. They spend 3 months on what we call the ambulatory rotation. So this was an opportunity as we increased from 3 to 4 residents per year. We could have a resident who spends time pretty dedicated in the ambulatory setting. Early on here, our PGY2 resident is in clinic alongside our attendings so that they can witness the clinic side of urology. Everyone loves to operate. Of course we do. That's why we're surgeons. But there's so much patient care that happens outside of the operating room. And there's so much of urology that actually isn't even surgical. So this is where we learn a lot of our clinical urology. And then with this being early on in training, then the residents are able to apply what they have learned on their ambulatory rotation as they are in other clinic settings that tend to be a little bit more resident run, such as at the VA. So that when they're trying to have a prostate cancer discussion with their patient, when they're a chief resident, they can harken back and think, well, what would Dr. So-and-so do in this situation? Also within the PGY2 year, we have a Barnes Jewish Hospital consult resident rotation. So this resident serves as the main point person to help run our consult service. Meaning at Barnes Jewish Hospital, if there are other inpatient services such as medicine, neurology, cardiology, etc., who have a patient with a urologic need, they will consult urology. Or in the emergency room, if somebody shows up with an obstructing kidney stone and they want a urology consult, then it is our consult resident who is the main point of contact. That being said, the consult resident works side by side with one of our nurse practitioners who is also dedicated to the consult service, so they make for a great team. The PGY2 resident also spends 3 months as the junior resident at St. Louis Children's Hospital on our pediatric urology service. In the PGY3 year, this is also split into 4 different 3-month rotations. 3 months are spent at the VA hospital. 3 months are spent at Barnes Jewish Hospital on what we call our main service. There's 2 different services, if you will, at Barnes Jewish Hospital. And you could say it's kind of artificially created. We looked at our attendings who typically operate at Barnes Jewish Hospital. I kind of put them in 2 different buckets, if you will. One service is more focused on endourology, minimally invasive surgery. So those are surgeons who do a lot of stone work, laparoscopic work, robotic work. Their patients are admitted under the endourology service. And then our other patients are admitted onto the main service. So that's a lot of our reconstructive urology or our patients who have undergone a cancer surgery will be admitted to the Barnes Jewish Hospital main service. So PGY3 resident spends 3 months as the junior resident on the main service at Barnes Jewish Hospital, working alongside a chief resident. And then there is another 3 months that are spent at Barnes Jewish Hospital, but this time as the junior resident on the endourology service, working with our chief resident for the endourology service. And then finally, the PGY3 resident will be spending 3 months at Barnes Jewish West County Hospital. So our residents go to several different locations. Barnes Jewish West County Hospital, it's about a 20-minute drive west of our main campus from Barnes Jewish Hospital. And our West County Hospital is admittedly where a lot of our healthier patients go. We still do a lot of major surgeries out there. but it tends to be more where the healthier patients have their surgery and are admitted post-operatively. So the PGY3 resident will spend 3 months out at Barnes-Jewish West County Hospital working with our attendings out there. In the PGY4 year, this is also divided up into 4 different 3-month rotations. 3 months are spent at the VA hospital, and it's at this time that our residents really become extremely proficient in more endourology type surgeries. So they could do with their eyes closed a TURP, a TURBT. Certainly at this point, they have learned to be very good at ureteroscopy. And then they're also starting to help our chief resident in some of the robotic surgeries at the VA, and I'll get to that in a bit. Our PGY4 residents also spend 3 months at Christian Hospital Northeast. This is a hospital that several years ago, several of our urology attendings started basing their practice there. And it's more in the northern part of St. Louis City. And this is an area of St. Louis City that had traditionally met challenges accessing healthcare. This is a part of the city where a lot of people might have limited access to healthcare insurance, but our attendings go out there and provide them with the same excellent urologic care. In talking with our attendings who go to Christian Hospital, when we began this rotation for our residents as our program grew, those attendings maintain a firm commitment to this being a very strong surgical experience for our PGY4 residents, and they have very much enjoyed being out there. And it runs the gamut. You know, we at Christian Hospital still do prostatectomies, partial nephrectomies, endourology. One of our surgeons who places an awful lot of IPPs, he's based out of Christian Hospital. So it's been a wonderful surgical experience for our PGY4 residents. In the PGY4 year, as we've increased our number of residents, we had a little increase in bandwidth so that our residents could start to explore more elective type opportunities. For instance, if our residents are anticipating what life after residency is going to be, and they think to themselves, you know, well, maybe I'm not going to do a fellowship, but I'm going to go into private practice. And I anticipate that I would be really wanting to focus on a certain area of urology. And I really want to hone my knowledge and my skills in that area of urology, then that's what I'm going to spend some time focusing on. And this is also an opportunity for our residents who are interested in working on some research projects. This is a good chance for them to bring those projects to fruition. You will notice also the word firefighter within this rotation, and that's because we are still an extremely busy program. And probably out of the 5 work days in a week, this PGY4 resident is still spending 2 of those 5 days participating in urologic surgeries, mostly at our main campus of Barnes-Jewish Hospital. And when they are pulled, if you will, from some research time or elective time, it is to cover cases that are absolutely level appropriate, meaning the chief resident who makes the assignments for the week takes a look at the schedule and says, wow, there's 2 cystectomies going at the same time and I'm only one chief. Well, in that case, perhaps the PGY4 firefighter resident gets an opportunity to first assist in a cystectomy that day. Also within the PGY4 year, the residents spend 3 months back at St. Louis Children's Hospital as the senior resident who is running our pediatric urology service. So there's a total of 6 months of pediatric experience within our residency program. And then this year is our last year of having 3 chief residents. And so their year is split up into 3 different 4-month rotations. So they spend 4 months as the chief resident at the VA hospital. I mentioned earlier performing robotic surgeries there. We do have a robot at the VA, and so this is a great opportunity for our chief residents to become very proficient in performing robotic prostatectomies or robotic partial nephrectomies. And then the chief residents also spend 4 months as the chief running the main service at Barnes-Jewish Hospital. Again, that's the service that focuses more on reconstructive urology and oncology. And then they spend 4 months as the chief resident on the endourology service at Barnes-Jewish Hospital. So that's the service that focuses more on minimally invasive robotic surgery, laparoscopic surgery, endourology. So there's a lot going on here, and we certainly keep everyone very busy. But by the end of it, we have ensured that we have some very well-trained residents. So call, it's a dirty word, right? Nobody ever wants to take call, but that's by necessity a part of the calling of being a physician and a surgeon. And so I'm going to go through our call schedule. Admittedly, it's kind of complicated, but it's complicated in the best possible way. When we went to our current call schedule system several years ago, it was at the request of our residents, and they, from start to finish, had a hand in fashioning what the call schedule is. Please feel free to ask them directly in the Friday night happy hour, or when you're interviewing with some of our residents on the Saturday interview day, ask them about the call schedule. And I think as far as call goes, it's one that's pretty doable, if you will. So when you're at the VA, that's all home call. I think that with 4 residents sharing the call responsibilities at the VA, that makes that very livable. Our interns, whenever they are on a general surgery service or urology in their intern year, call is basically every 4th night they take call in-house, which means, of course, post-call after there has been appropriate transition of care and handoff, they get to go home. And then in our PGY2 year, when you are not at the VA hospital, at that point, then you are in what we call our combined call pool. So several years ago, when we were revamping our call schedule, we recognized that probably the busiest place whenever somebody was taking call was Barnes-Jewish Hospital, certainly much busier than St. Louis Children's Hospital. Not that we don't sometimes have our busy nights at Children's Hospital too. But in order to kind of more equitably distribute the call burden, if you will, what we ended up deciding was on weeknights, so Monday, Tuesday, Wednesday, Thursday, both the residents at Children's Hospital and at Barnes-Jewish Hospital would participate in a shared combined call pool. Meaning, whenever you're taking call on those weeknights, you are covering both Barnes-Jewish Hospital as well as St. Louis Children's Hospital. And they are just across the street from each other, connected by a link. So geographically, that's extremely doable. But what this allowed us to do was to take the pie of call, if you will, and to cut it into more slices so that each person's slice of the call pie was just a little bit smaller. That way then it wasn't just those residents who were on the Barnes-Jewish Hospital service taking call to cover Barnes-Jewish Hospital overnight and taking a lot of call on that rotation. And I think this really helps to spread things out so that it's all much more livable. Now, when our residents above the intern or PGY1 year are taking call for urology, what is it that they're doing? Well, they're not the people who are at that point directly responsible for our inpatient urology service. The people who are directly responsible for our inpatient urology service are our interns who are in-house. And then if they have questions or concerns, the person that they're supposed to talk to lean on is the chief resident who oversees that service, who knows their patients inside and out. Certainly the PGY234 resident can be a resource to the intern, but that's not intended to be the primary focus of our PGY234 residents when they're taking that overnight call covering both Barnes-Jewish Hospital and St. Louis Children's Hospital. What the PGY234 residents are supposed to be focused on when they're covering overnight call is being responsible for our consult service, whether that's tending to the needs of established consult patients, or if there are new consults that come in, again, whether that be from other inpatient services like medicine or cardiology, or whether that be through the emergency room. And again, that's covering both Barnes-Jewish Hospital as well as St. Louis Children's Hospital. They also then can sometimes field phone calls from established patients who have questions at home. Those are the primary responsibilities for those residents when they're on call overnight. Now, admittedly, as you can tell from the description, that sounds pretty busy, right? And as a consequence, when we revamped our call schedule, we recognized we had to be very honest with ourselves. We used to be all home call, regardless of where residents were outside of intern year, regardless of which hospital they were at, regardless of which rotation they were on. We said, oh, it's home call. And it's okay to take home call if that's what it's actually going to be. If you call it home call, then that means that, oh, it was just home call, you still work the next day. And that wasn't really fair, because sure, maybe the residents who were taking home call got to be home here or there for little windows, some nights. And then there were some nights that people were in the hospital at Barnes-Jewish Hospital all night long taking home call. And so we said, you know what, when we revamped this schedule for the weeknights, we're going to say it's in-house call. Just call a spade, recognize it is what it is. And so yes, our residents stay here in-house Monday, Tuesday, Wednesday, Thursday overnight, tending to these needs. But that also means then the next day, after they have transitioned care of the patients, you go home. Now, if it was a bad call night, you go home and sleep it off. If it happened to be a good call night, well, then that's also your opportunity to get life done, right? So you could get your oil changed. You could go to the grocery store. If it was a good night, you could also go across the street to our simulation lab and practice on the robotic trainer. And I'll get to that in a little bit. We also have some of our residents who use it as, you could say, a travel day when they're putting together the call schedule. If they know that they want to be able to, you could say, start their weekend a little bit early, maybe they take call on a Thursday night so that they know they're going to be out the door come Friday morning and can already be hitting the road. So there's certainly an upshot to in-house call. That being said, once we hit the weekends, we recognize sometimes, if we're lucky, life slows down just a little bit on the weekends, and we didn't want to hold people hostage in the hospital with in-house call come the weekends. So on the weekends, Friday night, Saturday, and Sunday, we revert to a home call system, meaning once things do slow down, feel free to get out of the hospital, go enjoy your weekend. You might get called back in, but you can also hopefully spend some time outside of the hospital on the weekends. Also, what's different about the weekends is on the weekends, our children's service and our Barnes-Jewish Hospital service go their separate ways again, meaning on the weekends, it's just the residents who are at Children's Hospital who are alternating covering weekends with each other, where one weekend, Friday, Saturday, Sunday, it's the junior resident at Children's Hospital who's responsible for the pediatric urology service, and the next weekend, it's the senior resident at Children's Hospital who's responsible for covering the pediatric urology service. Over at Barnes-Jewish Hospital, all these residents who are participating in the call pool at Barnes-Jewish Hospital, again, they ran on the service, hopefully get to leave at some point for the weekend. But they also, several years ago, when we revised our call schedule, decided they wanted to go to a power weekend structure. And so what that means is once you're on call that weekend, once 6 p.m. Friday night hits, you are responsible for Barnes-Jewish Hospital call until 6 p.m. Sunday night. So that's 48 hours straight, which could sometimes be a really busy 48 hours. Sometimes not so busy. And then somebody else comes on at 6 p.m. Sunday night to help that person sleep it off, if you will, and covers Sunday night 6 p.m. to into Monday morning. And the upshot to a power weekend structure is that means it's that one particular resident's tough weekend, but that means there's all these other residents who are totally free of clinical responsibilities for a full weekend. And so generally with as many residents as we have now, our residents have essentially one power weekend every 4 to 5 weeks. So that means that they've got another 3 to 4 weekends that they're totally free of clinical responsibilities. Again, I know this is a pretty complicated system. If you've got questions about it, please don't hesitate to ask our residents, or in the interview experience, ask me about it. We're happy to explain it a little bit more. And then once you get to be a chief, you're all back up at that point. Doesn't mean it's always going to be a super quiet night. If there's a big surgery that needs to go in the middle of the night, especially a trauma, not uncommonly the chief resident will get called in. Or if there's issues going on with some patients on your inpatient service, whether it's main or endo, the intern might be calling you with some questions. You're also intended to be back up to the combined call pool, meaning if on a Tuesday night something's going down in both Barnes-Jewish Hospital and St. Louis Children's Hospital, say there's a septic obstructed stone patient at Barnes and there's a testicular torsion at Children's Hospital, one person can't be in 2 places at the same time. And so a chief resident would come in to help with covering those 2 different pressing needs there. So again, I know it's a pretty complicated system, but it's one that was created entirely with the input of our residents. And so I think they're pretty happy with it. All right, so over the course of 5 years, we are training surgeons. And just like an NBA player stands at the free throw line and throws free throw after free throw, similarly to get to be a good surgeon, you got to do surgery after surgery after surgery. And one of the ways that we can track how much training are we giving our patients, how much training are we giving our residents is their case logs. ACGME requires all residents to log their cases. And so this way we can see what is it that our residents are doing over the course of 5 years. Several years ago, I thought, well, let's see what our residents are doing. Certainly by the end of residency, every chief I know had always met their requirements, but I wanted to see to what extent are we meeting these requirements and perhaps exceeding them. And so looking at 5 years worth of data for graduating chief residents, I averaged out and found that the chief resident on average had been in over 1,600 cases. And the ACGME also breaks down different surgical procedures into different surgical domains, if you will, as you can see on this slide here: general urology, endourology, reconstructive surgery, oncology, and pediatrics. And they set forth some required numbers that people have to hit by the end of residency. And I took a look at these numbers and I said, well, we don't want to just hit the minimum. We want to be even above and beyond that. And so the factor by which our average graduating chief resident exceeds these required numbers, you can see here, it's by a lot. And especially in pediatrics, we've got a lot of volume going on here. And so I think if you ask our residents, they will tell you when it comes to surgical training, by the end of residency, they feel like they are competent and confident surgeons. So much so that many of our residents feel very comfortable going into private practice directly after residency. And when I talk to them in the years after they have graduated, they tell me, yes, absolutely, they were prepared. So it's not just doing, it's also learning. So we have an educational curriculum, and it is on a 2-year rotating basis that we intend to get through all facets, all subject matter within urology every 2 years. And this is based primarily on the online AUA University core curriculum that you can find on the AUA website. So that over the course of your residency, you will have heard about all of urology at least twice over, if not more. Every Wednesday morning, we have 2 consecutive hours dedicated to education. The first of those hours runs from 7 to 8 a.m. And that is for a broader audience, if you will. So that's where our attendings participate, residents, fellows, NPs, other members of our division. The second hour that runs from 8 to 9 a.m. is more geared specifically towards the residents. And we go on a rotating basis over the course of the month through different types of conferences. The second Wednesday of every month, we have a dedicated morbidity and mortality conference that's conducted in a root cause analysis fashion. The third Wednesday of every month, we have a multidisciplinary cancer conference. So this is when some of our more challenging cancer cases are presented, and we have our colleagues in pathology, radiology, medical oncology, radiation oncology there, so that collectively we can try to come up with the best path forward for these patients. Again, the second hour of conference is more geared towards the residents. And so it's a combination of looking at the subject matter that's curriculum based, again, from the AUA Online University, as well as practicing for oral boards and then doing a journal club. Outside of these dedicated 2 hours every Wednesday morning, we have additional conferences. Every Tuesday morning at Children's Hospital, we have an indications conference looking at our upcoming pediatric urology surgical cases in the subsequent week. And then on Friday mornings, there's also another cancer conference. Lots of cancer discussion around here. We try to be very respectful of this educational time. We have nurse practitioners who help with managing our inpatient services during the day, as well as a nurse practitioner who helps with covering our consult service. And so they are responsible for those areas while our residents get to focus on education on a Wednesday morning. Other educational opportunities. So we have several formal visiting professorships every year. Our longstanding annual visiting professorship is the Justin J. Cordonnier Visiting Professorship, which began in 1975. And if you look at this slide here, you can see a lot of big names in the world of urology that have come as our visiting professors here. This was our last in-person visiting professor in 2020, right before COVID really exploded. We had Dr. Sam Chang. Our Cordonnier visiting professor for 2021 was Dr. Ben Breyer from UCSF, which had to be virtual on account of COVID, unfortunately. We also have our John R. Koch Visiting Professorship. This one began a little more recently in 2017, and we hold it annually. It coincides with our very last day of the academic year each year, and then that evening we honor our graduating chief residents with a celebration. You can see in 2020, that was our first foray into a virtual visiting professorship when Dr. Peggy Pearl was kind enough to join us virtually. And then we remained virtual in 2021 when Dr. Stuart Wolf was our Koch visiting professor. These visiting professors, what helps us to decide whom to invite is someone who has a prior affiliation with Washington University, whether they're someone who previously was a fellow here or a resident here. And then we also, not annually, but still somewhat regularly, have a Manly pediatric urology visiting professorship. So in 2021, Dr. Chris Cooper joined us as our virtual Manly visiting professor. Also, it's very important to us that our residents have opportunities to practice and hone their surgical skills outside of the actual operating room on an actual real life patient. And we have within our main medical campus, the WISE Center or the WISE Lab, which is dedicated to simulation opportunities to bolster surgical education. So over there, we have a robotic simulator trainer, which you can see a photo here of Dr. Rudstrom in the green scrubs was on the robotic simulator trainer at that time. We also had for a period of time a traveling SP robot simulator that came through that our residents got to work on. We go over to the WISE Lab regularly, both as an individual opportunity. If a resident says, I got a light day, I'm going to go on over and help on the robotic trainer. But then also as a group. Just last night, the Associate Residency Program Director, Dr. Jason Frankel, spent the evening with our PGY 1 and 2 residents working on knot tying and basic suturing skills. We also have a rotating schedule for our residents to go 2 at a time over to the WISE Lab to work on an ex vivo porcine model using a pig kidney to practice robotic partial nephrectomies. We also have set it up where they can practice with the robot simulator there, vesico-urethral anastomoses, so that they're able to work on these skills outside of actual operating room. Other skills training we regularly have every year in endourology skills lab. So this is a Saturday when we have representatives from several different companies like Boston Scientific and Coloplast, et cetera, who provide equipment so that our residents can practice their endourology skills like ureteroscopy, getting access for percutaneous nephrolithotomy. You can see in this photo, one of our residents was willing to be the volunteer to use ultrasound guided practice for access for percutaneous nephrolithotomy. Mind you, all they did was take ultrasound pictures of her kidneys. They did not actually stick any needles in any human beings when they were practicing this. We also recently had an IPP lab. That's one that we have at least once a year as well as a lab about annually that we practice artificial urethral sphincter and sling placement. So lots of opportunity to practice these skills outside of the operating room. So why does all of this matter? Well, we want to prepare our residents for their boards, both part 1 and part 2, and we also want to prepare them for independent practice, whether that's directly after residency training or onto fellowship and then into practice thereafter. So what does happen to our residents after they finish their training here? Well, looking at the last 20 years, a little over half have gone on to fellowships finishing residency. And the fellowships that our residents have gone on to have included all the subspecialties within urology. And you can see that they have gone on to very competitive fellowships all across the country and some even across the world. But that also means close to half of our residents when they graduate have felt very comfortable graduating and going directly into practice. And so I think that's a strength of our program, that no matter where you plan to end up or where you don't necessarily plan, but life takes you, you're ready, you're prepared. While our residents are here, we pay them. And I think as far as salaries go, it's a pretty reasonable salary, especially given the very affordable cost of living here in St. Louis. The other thing about the salaries that are paid to our residents is that every year there's a cost of living adjustment, i.e. raise. And that was even after COVID hit. Residents continue to get a little bit of a raise every single year. As a consequence, between the salaries being what they are and cost of living being what it is here in St. Louis, our residents are able to purchase their own homes, whether that's a house or townhome or condo. Of course, we've got plenty of residents who also rent. We have some residents who are, if you will, they're breadwinners, where they're able to support a partner and a child or children off of one resident's salary. If you've got questions about kind of the cost of living in St. Louis and how affordable is everything here, please don't hesitate to ask our residents. Other benefits. So each resident gets 30 days of paid leave per year. 10 of those days are set aside as sick leave, whether that is our residents' own personal illness or if they have an ill family member, whether it's their child or another family member that they need to help with, they can apply their 10 days of sick leave. And that means 20 days of other paid time off. Out of those 20 days, 15 are earmarked as vacation. So each of our residents gets 3 weeks of vacation a year. When the residents make their vacation schedule for the year, we make it such that cross-referencing the vacation schedule with the call schedule, the residents are getting not only those 5 days off Monday through Friday, but they're also getting the weekends that are bookending that week off. So essentially people are getting 9 days consecutively off per week of vacation. And then at least 5 days other out of that paid time off per year. So this is where people will apply time to go for job interviews, fellowship interviews, or take off for medical mission work. A couple of years ago, also, our hospital system changed their leave policy to include bereavement leave. So this is on top of the 30 days of paid leave. If unfortunately a tragic event strikes your family, you lose someone, then per event, you get 3 days of bereavement leave that are paid time away on top of the 30 days of PTO. We also very strongly encourage people not to use vacation days to take care of themselves. If you've got a doctor's appointment and you just need to be gone for a couple of hours in the middle of the day, well, we're going to make sure that there's appropriate coverage arranged so that you don't have to use a day of vacation to go take care of yourself and see your doctor. We also encourage conference travel for our residents. You do not have to apply any of your PTO or vacation days in order to attend a conference. If you have seen a research project through and submitted an abstract and it's selected and you're going to get to present your abstract at a conference, then we want to encourage you to go, and we will give you time to be able to travel there, present, and return. And we will also reimburse you up to $1,600 per conference that you're presenting at. We've got several special priorities within the Division of Urology, one of which is patient safety and quality improvement. We take this very seriously. We have an online event reporting system that our residents are encouraged to enter in events. It is reviewed weekly, and then we close the loop and we follow up and follow through and try to figure out if there are changes that we need to make on a systems level to improve patient care. And then over the course of 5 years, each resident is encouraged to submit an abstract within the realm of PSQI to the Department of Surgery Annual Symposium for PSQI. And urology has been well represented at this symposium every year. This photo is a year when Dr. Kifudu, who's now one of our attendings, but once upon a time was a fellow here, he won an award at the symposium when he looked at our postoperative pathway caring for patients who've had ureteroscopy. Other special priorities to us, we want to encourage our residents to participate in medical mission work. You can see here some of our past residents who have been on mission trips. In the left there is Dr. Tammy Ho performing a TERP, and on the right is Dr. Mike Glamour. He's performing the first laparoscopic nephrectomy that was ever done in Haiti. Another special priority to us is wellness. This is something that I think honestly can't be emphasized enough. And that's on every level, right? That's not just the residents, that's the fellows, the attendings, the hospital staff, the nursing staff. I think it's something that is important for all of us to keep in mind. And this is also not just within urology, this is a priority for our hospital, for our institution. And as such, the Graduate Medical Education Committee for Washington University has appointed a director of wellness who helps to oversee this for all GME, meaning for all residency programs, all fellowship programs at our hospital, at our institution. They help to provide educational materials on things like burnout and resilience and mindfulness. Annually, we administer the Mayo Wellbeing Index to take the temperature of the well-being of our trainees. Results are anonymous, but they do share with me as the program director what were the results for our program as a whole, so I can have some insight into what's going on with our residents. We also have a wellness committee made up of resident champions from across the institution who participate and talk about and help to improve such things as leave policy, food access, lactation policy. We also have mental health resources made available to all of our residents across the institution. So the GME actually has on staff a couple of psychologists who are available full-time to the house staff, and those are to provide completely protected sessions after hours, weekends, and it's totally free of charge for anyone who wants to seek those services. We also have a physician peer support program if somebody feels like they need to talk to a peer, somebody else who can appreciate and understand things that they're going through. We want to support each other. We also try to maintain an appropriate education to service balance. So as I mentioned before, we've got protected educational time, and we also try to minimize non-physician obligations. We've got some wonderful nurse practitioners who help us both with our inpatient service as well as our consult service. Part of wellness is having fun sometimes too. We are trying to get back in the swing of things despite COVID with having regular gatherings as a division. So some of these photos show some of the activities we've done together. We had a wine and painting evening when we fancied ourselves as artistes. We have holiday parties with karaoke. We've gone shooting each other, playing paintball, escape rooms. This was a photo this last summer. I think it was like end of July, right before Delta variant hit, when we were able to have a wonderful barbecue at a local park all together. There was a lady who like made balloon animals, and there was like face painting and barbecue. It was awesome. And then a more recent photo on the upper left, some of our residents got together and went to a recreational park called Amp Up, where they could do like wall climbing and hanging from ropes. And then there was a mentorship gathering that I had with my mentorship group in Forest Park on like the most perfect day ever. And we hung out and talked and played washers. Along the lines of mentorship, there is certainly organic mentorship that happens all on its own. Say you find over the course of your residency, you're gravitating towards reconstructive urology, and you and Dr. Greg Murphy bond over reconstructive urology, and he fosters your growth in that area. Organic mentorship is great, but I think it's also important for mentorship to be very intentional and deliberate. And so we have mentorship groups. So it's a group of residents who are stratified across training, meaning each group will have like a PGY 1 through 5 of residents, and then a couple of faculty mentors per group. And we try to get together from time to time and talk about life, talk about work, and are just very honest with each other. And then these are some photos. Also, you can tell we like to eat. Admittedly, these big group photos in restaurant type settings were pre-COVID, but hopefully we're able to get back to this again. So I just wanted to end by talking about, what is the Washu Urology brand? What do we value? What are our North Stars? We very much honor innovation and improvement. So whether that's using the latest and greatest surgical devices, or whether that's figuring out how do we build a better mousetrap when it comes to patient care protocols and pathways. We want to be always pushing ourselves to do things better. We also honor a commitment to excellence. So that means holding ourselves accountable as an individual and as a program. And we want to be excellent to take care of our current patients as well as our future patients. And so that means also a commitment to respect and integrity as well. And then finally, I think one of our other big North Stars is teamwork. We take care of each other. You know, every year I hear stories amongst our residents about how they help to take care of each other, whether it's at work. You know, someone who's had a rough day and come the end of the day has several consults that they have yet to tend to. And someone who just out of the kindness of their heart says, well, give me half the consults, you know, let's divide and conquer and work on this together, even though they don't have to. Or whether it's seeing how our residents support each other outside of work as well. I think that that's one of the greatest strengths of our residency program, and one that makes me really proud of our program and of our residents. So thank you very much for listening to this presentation. I hope it gave you some pretty good insight into our program in advance of your interview with us. Obviously, we want to give you plenty of opportunity to ask additional questions that you have, whether it's in the Friday night happy hour with our residents or on the interview Saturday itself. I look forward to meeting each and every one of you. And thanks for going on this adventure with us as we're doing virtual interviews yet again. I can't wait to meet you. Thank you.